Hi everyone, Cassy Adams here, Care Services Director with the ALS Association, Oregon Southwest Washington chapter. I'm really excited to be here with all of you today. Today is the first of a series of some educational events that we're going to be putting on twice per month on Facebook Live. And these events will serve as a platform for us to just share information with all of you and strategies for preserving quality of life for people living with ALS and their support team. Today is a live event, so myself and Dr. Libby are here to help answer questions that all of you have. So we are inviting all of you to ask your questions in the comment section in Facebook, and we are going to do our very best to have Dr. Libby answer your questions. However, if we don't get to all of the questions today, we will make sure to get responses to all of you in that chat box afterwards. So I'm very, very excited to be able to introduce Dr. Libby, who's here with us today. For those of you who don't know Dr. Libby, he is a pulmonologist and critical care physician for the Oregon Clinic, and he is the lead pulmonologist at the Providence ALS Multidisciplinary Certified Center of Excellence. He also serves on the ALS Association's National Board of Trustees and is on the Oregon and Southwest Washington Board. Welcome, Dr. Libby. Thanks for being here.
My pleasure. My pleasure. Thank you for that nice introduction.
Absolutely. So
in the days of social distancing that we can get together like this.
It is really, really nice, and really appreciating how technology is here for all of us in this time and giving us the ability to connect with one another.
Totally agree.
So we are here today to talk about COVID-19 and its impact on people living with ALS. So we invite all of you to ask your questions, but one of the big burning questions that I've been hearing for the last several weeks has just really been how are you seeing this virus play out, and especially in its impact on people living with ALS?
Sure. Well, to my knowledge, to date, fortunately, there have been no patients with ALS who've gotten the coronavirus and the COVID-19, both here in the state or in our chapter region, but also, at least as of last Friday, when I had a meeting with the national group, there have been no documented cases in any ALS patients around the United States that we know of. Of course, it's going to happen. It's reassuring. It hasn't happened yet, but we know it's going to happen. There's no way for it not to happen. Just statistically, some patients with ALS are going to encounter the virus. And fortunately, the good news is ALS does not affect immune systems in terms of our proteins and all the various things that fight stuff off. But in spite of that, ALS patients are certainly a high-risk group. And they're high risk because, and it depends on their symptoms and the stage of their ALS and whether it's bulbar or not. But every patient with ALS is considered high risk because they probably don't have the total strength they had before the diagnosis, and that includes the strength of coughing and breathing muscles. Even if they aren't feeling it yet, they probably have some effect. So they are at high risk, and I think they should do everything they can to avoid getting it. The social distancing, and just parenthetically, I like the word physical distancing. Mm-hmm. We want to socially connect and be socially close to people, but we don't want to be physically close to them. But I would recommend everyone practice as much extreme physical distancing as they can if they have ALS to protect themselves. And I know that's so much harder for someone with ALS who's dependent on their caregivers to be right there with them, touching them. Turning them, all sorts of things they can be doing.
Yeah, along those lines, what kind of precautions would you recommend that that caregivers, family caregivers, or caregivers that are coming into the home be taking to kind of help reduce the risk for people living with ALS?
Well, certainly a caregiver or family member, if they have symptoms of the coronavirus, and the common symptoms are fever, achiness, what we call myalgias, aching muscles, a stuffy nose, a sore throat, and especially a dry cough. All those are the common symptoms. There's some other less common symptoms, but those are the most common ones. If they have that, they should do their utmost to stay away. But I know the caregivers, the ALS patients are 100% dependent on caregivers. So if they have those symptoms, if they can stay away and there's some other caregiver, great. But if they can't, the things they can do is they can wash their hands compulsively, frequently, every time they touch their patient. And that might be 5 times an hour. You know, we all know how often ALS patients need to be touched. The other thing I've thought about, and maybe my thoughts about it have changed over the last few weeks, I think a caregiver with or without symptoms, if they can wear a simple mask, not the N95 mask, but a simple mask, it makes some sense. And that's assuming that the hospitals have enough of the true masks, the N95s and what we call the simple surgical mask. But you can just get a bandana. You can just get a homemade simple mask. And what it does is if you cough inadvertently, like I just did, it keeps the stuff from getting out there. So if in fact the coronavirus is in your mouth and you don't even have any symptoms, that little mask may help. So I would recommend caregivers in general wear a simple mask, not one that's been stolen from a hospital or taken from a hospital, but a homemade, do-it-yourself simple mask. Any material work. Cotton is fine. It prevents the big droplets, and that's the stuff that's most infectious, the big droplets from getting out. And then the hand washing and the distancing as best as you can. And I know that's probably different from what I've told people a week ago. These things evolve.
Absolutely. I think we're all kind of having to shift our mindset as we move along. So, well, and I'm glad that you brought up the DIY masks, because we've had a lot of people reaching out to the association in the last couple of weeks who have been making masks. So if anyone is looking for something and needs some support around that, feel free to give me or your care services coordinator a call, and we certainly can help link you up to get access to that. So also along those same lines, there have been a couple of questions about BiPAP and AVAP style ventilators that folks are using. In terms of a person who might be using one, but's got it in the closet for the last 6 months or so, and they're not really planning on using it. It's just kind of gathering dust. What would you recommend that person do? Should they send it back to help someone who else needs it, or hang on to it? What do you think?
Well, the what's called BiPAP or AVAPs machines are in general not a ventilator that can be used on. It's not the ventilator everyone's looking for the intensive care units. They cannot be used in that situation. They cannot be used with a tube that goes through the mouth or a tracheostomy. So sending it, I recommend sending it back if you're not using it, certainly if you're getting billed for it. But if you're thinking you might use it in the future, you can keep it. If you've already paid for it, if you own it, and that's, I think, in Cassy, you know the rules better than I do, but I think 13 months of rental and then they own it. If you own it, I'd just keep it. You may want to use it later in the course of ALS or not, but it's not going to take away from the stockpile of ventilators that we're going to need during the surge. That specific type of ventilator, they're called BiPAP or AVAPs generally. Now, Trilogy is different, and Voxen is different, and Astral is different. We could talk about those also, but in terms of the more common BiPAPs and AVAPs, don't worry about hoarding them and keeping them from a needy patient. But also don't realize it's not going to protect you either. It's not. If you get really sick, it's not adequate.
Okay. Good to know. Another question about ventilators or AVAPs, BiPAPs that came in was whether or not people should be cleaning their respiratory equipment more often right now, or should they be cleaning it in a different way to protect themselves better?
I think they probably ought to be cleaned more frequently because everyone's touching them a few times a day. So just the standard. It's probably just water and a little soap or alcohol or the Clorox types of wipes, those sorts of things would be appropriate. I think it's always important to make sure your filters are replaced on a regular basis, but those filters really are trapping more dust and pollen, things like that. But they have to be either replaced or cleaned. I forget which, but it's a little removable thing that you can clean. I believe there's a internal filter that you can't replace, that the companies replace if you return your machine and they refabricate it for someone else. They can replace that filter. And then I think there's a little filter on the outside that connects with the tubing. And that may only be on the Trilogies. I think that's just on the Trilogies. So don't worry. We can talk about that separately. If you have a Trilogy, there is a filter that's supposed to filter out 99.99% of viruses and bacteria and all sorts of things. And I think they're supposed to be replaced once a week. The Trilogies are the machines that are really ventilators. They could be used with a tracheostomy. They can be used with a tube in the mouth. They aren't commonly used in the hospital, but they can be used in a hospital. But if you have a Trilogy, your durable medical equipment company, the company comes out to service it or check on it, is supposed to come out once a month. So they make sure those filters are checked once a month at least, even though we tell people they should be changed once a week.
Great.
I think if I had a Trilogy and I was on it 24 hours a day, I might be changing that little filter that you're supposed to change once a week. I might change it more frequently, a couple times a week. I think they cost a couple dollars. I'm not sure exactly what they cost, but I'd probably change them more frequently personally during this time.
Yeah, might just be worth it.
Yep.
Okay. So question from Sam Beekman.
Hello, Sam.
Hi, Sam. Do you support any meds for COVID or for other treatments? And certainly we've been hearing a lot about azithromycin and hydrochloroquine and some of those meds. So what would you say?
I think in the ideal world, those prescription medications, hydroxychloroquine, which is a anti-malaria drug. It's also used for some arthritis. It's called Plaquenil in that situation. It's been available for a long time. It's a relatively safe drug. But it's got side effects, and I would not routinely take it unless your doctor prescribes it or you're in a study. And I know many of the hospitals in the Portland area are involved in a national study looking at that versus a placebo. My suspicion, and just so Sam and others know, the studies that have been done to date, the initial study that got everyone excited is a cell culture. They take cells, they infect them with the virus. One group they put in the hydroxychloroquine, one group they put in nothing. And the group that got the hydroxychloroquine, the virus grows less rapidly. So that's sort of exciting, but that doesn't mean it'll work in the body. The body's very, very different. So I'm skeptical about it working in people, but I think being in a study, that'd be great. If you aren't in a study, I know many patients in the Providence system and other health systems locally are getting it. Even if they don't qualify for a study, some of the doctors are prescribing it, and it is available in the hospitals. I don't think there's any data that taking it prophylactically so you don't get the virus makes any sense. And then you're putting yourself up for potential side effects and dangers.
Okay.
The other drug you mentioned, azithromycin, is a very common antibiotic. It's generally well tolerated. It used to be called a Z-Pack. It was a 5-day course. Day one, you took 2 pills, and then you took 1 pill a day for 4 more days. But the generic name is azithromycin, and it's used for common bacterial pneumonias. It also has an effect that enhances the immune system for some chronic lung diseases. So that's why people are interested in it. But again, it's got its own set of side effects and dangers. I would not use it without the order of a physician.
Okay, great. Another great question from Sam. If I get COVID, what benefit would the hospital be able to provide for me?
Great question, Sam. The hospital can provide a much higher level of oxygen than you can get at home. Most ALS patients are not on oxygen at home. They may be on their AVAPS machine or their Trilogy machine, but they're not on extra oxygen. Some do have some oxygen at home. Usually it's low flow, what we call about 2 liters per minute. Patients who get COVID-19 in the lung frequently need 15 or 30 liters per minute to get enough oxygen into the blood to get through the infection and the inflammation in the lungs. And that can't be done at home. So that's one of the things. And they can put a tube down and breathe much more successfully than the mask treatment that most patients are doing now. So they can do invasive ventilation, and at home you can only do non-invasive ventilation unless you have a tracheostomy already.
Mm-hmm. Okay, great. Thank you. These are great questions that everybody's got. I see another one coming in, but in the meantime, there was a question before we jumped on today about whether there's a role for zinc supplements to enhance kind of the immune system. You already talked a little bit about the immune system, but I don't know if you can talk specifically about zinc.
Yeah, I'm not a real expert on zinc, but what I know is there are a lot of over-the-counter supplements with zinc. I think a common one is called Zicam. I think that's a brand name. But so there's, and it's been used for the common cold for years. And I think, again, that the data to support it is very weak. But it's a pretty benign intervention. And I've had some people tell me, well, if it's so benign, I think I'm just going to take it because we all know there's a placebo effect. And if I'm taking something and thinking it's going to help, maybe it will help. I just warn you, problems, zinc might not be good for you. It might build up too much in you, especially with kidney problems. But if you're otherwise perfectly healthy, other than ALS, and you just take the amount that's recommended over the counter and the Zicam or other equivalent sort of supplements, it's probably not going to hurt. It's probably not going to help. But if it's good for your psyche, it's pretty safe.
Yeah. Okay. Well, and I think a perfect follow-up question to that is for those people who are feeling like they're going a little stir-crazy at home, as a physician, do you have any sense of how long this is going to continue in terms of physical distancing, in terms of just the way we're having to all live right now?
Yeah, I think this is going to go longer than any of us expected or wanted. One day is too much. This is hard, being socially isolated. And I know ALS patients are socially isolated anyways, too much. But my suspicion, and some of it's based on data that you can get online from the Institute it's the University of Washington, and they've got a physician leader named Murray, I think, but it's the Institute for Medical, IMLE, I think is the initials, and it's on CNN, and even President Trump and his advisors are talking about it now. But they have modeling, and the modeling they model by the country, they model by each state, and right now in Oregon they're saying our peak is going to be about May 1st. It varies day to day based on how many deaths we had the day before. Our peak is going to be May 1st, and it's going to tail off in June and probably be totally gone by August in terms of people dying from it. But it'll be quite minimal in July. And the whole issue is, when do we begin to get more liberal? And we certainly aren't going to get more liberal about social distancing before May, if that prediction is correct. And that's the peak. Then it has to come down. It comes down more slowly than it goes up. Interestingly, New York's peak is about April 15th, and Washington's peak is about April 10th or 11th. And the suspicion right now is we may sneak by without some of the terrible things that have happened elsewhere. I mean, there's going to be plenty of deaths in Oregon, but we may not get the enormous surge that's being seen in New York and was seen in Seattle, possibly because we started earlier. Relative to the number of patients we had with COVID-19 back 2 weeks ago, whereas we sort of did things within a day or two of Seattle, and they're probably 2 weeks ahead of us.
Okay. Interesting. Just to kind of go back for a second, you mentioned oxygen, and Donnie Graham is with us. Hi, Donnie. And Donnie had a question about O2. He says, I have a vent, but if I get sick, will I need O2?
Well, we don't really know what's going to happen to ALS patients because none have had it. But if we extrapolate from what happens to everyone else, if you're lucky, you get a fever, you get a stuffy nose, you get a sore throat, you get a dry cough, but you don't notice any difference in your breathing. And that's the healthy people who stay at home and isolate themselves for protection of others. And that may happen to patients with ALS, and you would not need extra oxygen. If it gets into the lungs and develops pneumonia, then you'll notice shortness of breath, and maybe you'll notice a low oxygen level. And I suspect Donnie has an oximeter. I don't know if he does or not, but I suspect he has one. And many ALS patients have one if they're on a lot of respiratory support. And you'll notice if you get short of breath and your oxygen level is going low, then you will need oxygen. And it's probably not just, oh, let's call my durable medical equipment company and they'll bring out oxygen. If your oxygen level is low, you'll have to go to the hospital, unfortunately. Because if it's low, it's likely to be lower the next day and the next day and the next day, and then it'll turn around eventually.
Yeah. Okay. Question about access to ALS clinics, and of course that access is somewhat limited right now. How are people knowing that something is going on that is acute enough to seek out face-to-face care? How are those decisions being made? And are you seeing patients live as well through the COVID-19 virus?
Patients in general live through it. 80% never need to go to the hospital. So 20% end up in the hospital. About 5% of all patients end up critically ill, meaning they go to the intensive care unit. They may have to be put on a ventilator. And we still think it's going to be around 1 or 2% who die. So the vast majority of patients who get COVID-19 are going to survive. I think the majority of patients with ALS will survive too, but it may not be 80%. So that was the first question, or the second question. The first question was more about the ALS clinics.
More about the ALS clinics, and I think
and
also
seen in person.
Exactly, and how would people go about making that decision, or who should they consult with before deciding to go in?
Well, most of the ALS clinics around the country, and certainly the ones in the Portland area, are becoming virtual clinics as much as possible. So I've had many phone calls with ALS patients, and I know a letter is going out from the ALS clinic that I work at Providence, basically telling patients this, but they're so backed up and they're trying to catch up with people and get onto the virtual visits that they haven't been able to get more than about a week out. So if you have an appointment in a month and you haven't heard from anyone, don't worry about it. They will be calling you to change your visit to a virtual visit if that seems appropriate. And I think all the rest of the clinics are doing the same thing, but they do have to sort of get caught up. There may be a delay before you get contacted. So when do you know that you should be seeing someone, and who should you contact? If you're connected with one of our clinics, whether it's the Kaiser Clinic or the Providence Clinic or the OHSU Clinic or the VA Clinic or the Southern Oregon Clinic or the Bend Clinic, I think that's all our clinics, isn't it?
I think you got them all, yes.
Okay. I would contact them. The clinic nurse coordinator will know exactly what to do with your issue. That's the best decision. If you think you're sick with COVID-19 and need more help, then you can call those people, but they are not going to see you. They will send you to a place that can, if you're having fever and respiratory problems, you're probably going to go to the ER, and they'll have a triage system where they test and decide if you should be admitted or not admitted. And probably in that situation, they'll be do testing to see if you have the COVID-19 virus or not. And realize in the state of Oregon, of all the testing that's been done, and it's done only on people that they think are sick from it, not just a little cold and a sniffle and a fever and stay at home. People who end up at the emergency room, out of all the tests done, only 5% have been positive so far. And a lot of tests turn out positive for influenza or other viruses, respiratory syncytial virus. There's lots of names of these things. But so just because you have all the symptoms that I've described and you've seen doesn't necessarily mean it's going to turn out to be the coronavirus.
Okay, great. We just got a question in from Nikki Rohan. The question is, we have home healthcare nurse scheduled to come into our home to access my husband's port for his next round of Radicava. Should we skip a cycle so that we don't have a healthcare worker coming into our home, or should we just take extra precautions by using gloves, masks, extra sanitization, etc.? It's a tough question.
That's a really good question. That is a really good question, and I think it depends. It depends on how you're doing with the Radicava, and if you feel it's helping you, I'd probably push to continue it. If you've been on it for 6, 9, 12 months, or even more than 12 months, and we don't have data beyond 12 months with Radicava, we know it probably continues to work. The original studies were 6 months. There's been some extensive extension studies that suggest it might help for 12 months. But if you're out a year or so and you aren't convinced it's helping things, I might say, I'm more scared about getting coronavirus than I am about going off Radicava. But it might be a good time to discuss it with your neurologist. Usually the neurologist has all that background, or at least the nurse in your ALS clinic. They'll all have a good feel for whether they think it's helping or not.
Yeah, and this question has come at me a couple of times in the last couple of weeks, and I know that that the nurses at the various clinics are working really hard with folks who are on Radicava to try to decide, based on those individual situations, kind of what makes the most sense for each person.
Yep.
All right. Oh, another great question from Sam Beekman. Thanks, Sam. Keep them coming. Are home PFTs available right now?
Great question. They are. They have been, and not in our system, not with ALS patients, but for example, patients who have lung transplant frequently monitor their breathing with a home PFT thing that they transmit through the phone to the transplant center. We have not set that up. I don't know of any ALS clinics that have set that up. I was just talking with our ALS nurses yesterday about that. How do we decide which patients we should do the testing on and which we should not? We weren't talking about home testing. We're just talking in general. And there's some milestones. The common milestones are if your breathing capacity drops below, it depends on the various tests, but if one type of test, if it becomes abnormal, you qualify for non-invasive ventilation. If you get down around 50%, even if you have no other problems swallowing, we usually recommend feeding tube at that point. Getting a feeding tube right now is very, very difficult. I won't say impossible, but very difficult. Once it gets down lower than that, decisions are made separate from the number. A breathing capacity of 30% versus 20% doesn't change much in terms of what we do. It has more to do with other symptoms. So it's earlier on in the disease, it might make a difference. I'm going to check with our ALS clinic, and maybe we'll check with the University of Washington where they do lung transplants and see if we can get that technology. That's a really good thought, Sam.
Absolutely. I totally agree. Going back up, and I apologize for skipping over this, but there's a question about kind of a two-part question. One, does hand sanitizer really even work? And the second part of that question is, let me see, are there certain hand soaps that are better for caregivers to be using at home?
I'll answer the first part of it first. Hand sanitizers work if they have the right stuff in them. And the right stuff is 70% alcohol or a higher percentage of alcohol. Or I think isopropyl alcohol is fine too. They don't work as well as soap and water, but they work. that they will kill virus rapidly. 10 to 20 seconds of rubbing that stuff and then letting it dry, and probably 99% of the virus is gone. Is it 100%? I don't know, but it's pretty darn good. Better than that is soap and water, but the right way to do soap and water is 20 seconds. Some people sing "Happy Birthday to Me," "Happy Birthday." You do the whole song, that takes 20 seconds. It's a long time. And soap, I think any soap that really is soap will work. The foaming soaps are good, the non-foaming, but I don't know of one soap that's better than another. Ivory is fine. Dishwasher soap is fine, but I don't think there's one that's better than others. But I'm not an expert in that area, and I'm not a microbiologist. But they all disrupt the membrane of the virus, and it's that alkali that does that.
Okay. So bottom line is definitely when you have access to soap and water,
yes,
do that.
Yeah.
I've heard of Staying Alive and a lot of other great versions of songs that you can wash your hands to if Happy Birthday gets a little too boring. Another question, just kind of about accessing respiratory equipment right now. Is there a short supply of things like tubing, masks, suctioning, catheters, any of those other kinds of pieces of equipment? We've been hearing about short supplies of other pieces of equipment.
I was just on the phone this morning with one of our larger DME companies locally, and they reassured me they are working. They're working from their offices. They don't want people coming in without appointments to protect everyone. And they have supplies of everything they need right now. So, and they are not foreseeing a shortage. But if I would be thinking ahead a few weeks and make sure you have at least 2 weeks of supplies available right now for whatever you use every day or once a week or whatever it is. Make sure you got it now and not wait till you just have a day or two, because there may be crunch time.
Okay. That's great advice. Robin McNeil has joined us, and she says, I'm due for my second shingles shot by June. Should I go into Fred Meyer's pharmacy or wait it out until this is all over and start again? That's a really good question. I think could apply also for things like flu shots or other preventative measures.
Yeah. Well, I have been telling people the last few weeks, get a flu shot if you haven't gotten one, because you don't want to get the flu, which we just had a sort of a second outbreak in February that sort of confused things. But you don't want to get the flu, which has pretty much the same symptoms: a dry cough, a fever, achy muscles, sometimes a stuffy nose or sore throat, and think you got COVID-19, or thinking, oh my God, I'm getting short of breath from this, end up in the ER, and then catch COVID-19 from someone who has it. So I've been recommending the flu shot. The shingles shot is not going to prevent anything that overlaps with COVID-19, so I don't think it's quite as important. And I think you're supposed to get it within 6 months, the two of them roughly 6 months apart. I think, yeah. I think right now I'd probably wait till June, hoping that we're on the down slope. Right now we're on the up slope. And if it took two more shots, if come June it still seems risky, I'd wait. I'd avoid all the contacts you can with ALS.
A question that's been coming up a lot has been what, if anything, can I be doing at home if I have, my AVAPs, my BiPAP, I might have a suction and a cough assist machine. Are there things that I can be doing right now to just help support my respiratory health, just help to keep myself as healthy as possible right now and preventing myself from getting this disease or getting COVID?
Yeah, I think, again, the social distancing, the physical distancing, the washing the hands, the covering the coughs and the sneezes, all that stuff is important for you and your caregivers. Beyond that, I think it's probably the things you're doing, assuming you're using all that equipment, especially the cough assist and the breath stacking and the AVAPs. if you're doing all those, maybe you only do the cough assist once a day because there's not much to cough up and it feels okay. I would up it to twice a day, just routinely. Just make sure anything down there is not staying down there, because the stuff down there is the source of pneumonia. There's a bacterial pneumonia or COVID-19 pneumonia. So I would be more aggressive with all those things. AVAPs, if you're using them 6 hours a night, try and do 7. If you're doing the cough once a day, do it twice a day. If you're doing it twice a day, maybe 3 times a day. Just be a little more aggressive with everything.
Yeah. Well, and we're coming up on our time, but I do have one more question that I think is probably a very difficult question to answer, and is going to be dependent on each and every person. But particularly as we're talking about ALS and a disease that we can't always predict and looks very different from person to person, when we're talking about COVID-19 and not really knowing how long this virus is going to continue, what would you say to folks who are wanting to see their grandkids, wanting to spend time with family, and just how important that is for our emotional and psychological health? What suggestions would you be giving people about that right now?
Well, I'd say it's a really hard question.
Yeah.
And I think it's a balancing act, like you say. It's a balancing between how risky is it for how like you said, how advanced is the ALS? If I'm really marginal, I want to be even more careful about physical distancing and isolation from the virus. If I just was diagnosed a week or 2 ago and I feel perfectly normal, other than maybe a little twitch or a little weakness in a hand or a foot, I might be a little more liberal about it. And it's also how recently you've seen this relative. Especially they don't understand hygiene. They don't understand physical distancing, and I think they're really high risk. And I would do what you and I are doing, Cassy, and that's Skype or FaceTime or whatever else there is out there to hook up with people as best we can. I know it's not perfect, and some kids are so young that they can't really understand that face on the screen is grandma. But if it's a 5-year-old or a 10-year-old, they can probably even a 3-year-old can certainly understand FaceTime and Skype, and that the picture up there is grandma. Mm-hmm. So I'd recommend using our social media tools to connect with family in that situation. I really worry that it's the 2 years old and the 4-year-olds who I'm sure they've had a sniffle in the last month, and that could have been COVID-19, and they may still be a carrier, and they're spewing it everywhere, and they're going to climb up on your lap because they love you, and you know where it's going to go, and then their hands are on your face, and who doesn't want to hug them? So.
Exactly. Yeah, that's such a good point. And I think we're all getting a crash course in using technology right now, and trying to make do. And I keep hearing about new apps and new ways of connecting with people that are pretty exciting. So I think we'll all find ways to kind of engage with one another during this time. So we have time for one more question, and this is another question from Robin. Even when things have flattened out, will it be safe enough for people with ALS to go out without a vaccine?
I wish I knew the answer to that, and I don't think anyone knows the answer to that, and I think we'll have a much better idea in a month or 2 or 3, and it'll depend on whether we develop antibodies in our blood, and there'll be a test for that. And if those antibodies fight off the virus, so when it comes around again, you don't get it, just like, we don't get measles because we got the shot for it. Even though it's a little bit around in the community, we don't get it. And it'll depend on how many people have developed those antibodies. So if lots of people have them and you don't because you were so good about social distancing, you're probably pretty well protected. If 90% of the people out there have the antibodies and they work, then you will be protected because 9 out of 10 people won't be carrying it. So that and testing to see who might be asymptomatic carriers, I think, maybe by midsummer, maybe by the fall, we'll all feel a lot more comfortable.
Yeah.
But it may be that the antibiotics don't work very well, or they're only temporary for a few months, and then we have to wait for a vaccine that really gives us long-standing, or at least year-long protection.
Mm-hmm. Well, it sounds like, we're going to know and learn so much more as the months come ahead. But, the information I think that you've shared today, Dr. Libby, has been really, really useful, really helpful, wonderful questions coming in from everybody.
Yep.
I'm, really feeling that although we are separated right now physically from one another, in many ways, this kind of technology can keep us a little bit closer and keeping in touch with one another. So I want to just encourage everybody who's watching out there, we're all still working, we're all still here for you, and want to just be able to help support, answer questions that people have. The next streaming event that we're going to be doing, if you want to mark your calendars, is April 22nd. It's also a Wednesday. And we're going to be bringing our assistive technology coordinator, Amanda Mason, on. And she's going to talk a little bit about just that. How can we stay connected with each other, and how can we communicate perhaps in some very different ways when we're affected by ALS and speech is impacted, and particularly for people who are using speech generating devices, what are some ways that they can really stay connected and to the people that they love, and the little people who are trying to stay away so that we're not spreading this kind of stuff. So Dr. Libby, thank you again so much for joining us today. It's been really nice to have you on, and thank you to everybody who's asked questions. If you have any other questions that come up, don't hesitate to put them in the box, and we will do our best to answer them after the live stream. And today has been recorded, and we are going to be sharing that link out. So if there's anybody who didn't get a chance to watch today, or you want to share it with friends or family or anybody else who's interested, please do.
Thank you, Cassy. That was wonderful.
Yeah, thank you. We'll talk again
moderator,
soon.
And I will second your thought about social media and social technology helping us stay connected.
Yeah. Well, really appreciate that it allowed us to do this today.
Sure.
So, all right. Well, thanks everybody for joining us. We really appreciate it, and hope you and your family are all well and staying safe. All right.